Calorics. Water that is colder or warmer than body temperature when applied to the tympanic membrane changes the firing rate of the ipsilateral vestibular nerve, causing ocular deviation and nystagmus. Cold water normally induces a slow ipsilateral deviation with contralateral corrective phases. Warm water induces a slow contralateral deviation and ipsilateral fast phases. Since the direction of nystagmus is conventionally described as that of the fast phase, the mnemonic COWS, cold opposite, warm same, indicates the direction of caloric nystagmus for cold and warm stimuli. Bilateral irrigation induces vertical nystagmus. The mnemonic CUD, cold up, warm down, refers to the fast phases. Caloric testing may be done at the bedside or quantitatively in a laboratory. Quantitative caloric testing is used to evaluate vestibular function. Bedside caloric testing is used to establish the integrity of the ocular motor system in patients with an apparent gaze paresis and to evaluate altered states of consciousness. Caloric stimulation may be used to elicit vestibular eye movements if oculocephalic maneuvers have negative results or when a cervical injury is suspected. Bedside caloric testing is performed after the external auditory canal has been examined, the impacted cerumen removed, and the tympanic membrane established to be intact. The head is elevated 30 degrees from horizontal, aligning the horizontal semicircular canal in the vertical plane and maximizing lateral horizontal nystagmus. Water is gently injected with a syringe through a soft catheter inserted in the external auditory canal. Usually 1 ml of ice water is sufficient in alert patients and minimizes discomfort. Up to 100 ml of ice water can be used in unresponsive patients, and several minutes should be allowed for a response. Irrigation is repeated in the opposite ear after waiting at least 5 minutes for vestibular equilibration. Warm water, 44 degrees Celsius, may also be used. Because of the risk of thermal injury, hot water should never be used. Eye movements elicited by vestibular stimuli, whether passive head rotation or caloric, may allow localization within the ocular motor system. Impaired movement of both eyes to one side occurs with lesions of the ipsilateral paramedian pontine reticular formation. Impaired abduction in one eye suggests a palsy of cranial nerve 6. Impaired adduction is seen in third nerve palsies and in the eye ipsilateral to a medial longitudinal fasciculus lesion. Bilateral internuclear ophthalmoplegias cause, in addition to bilateral adduction weakness, impaired vertical vestibular eye movements. Eye deviation may occur in aberrant directions in patients with drug intoxication or structural disease of central vestibular connections. As consciousness declines, the caloric stimulus induced eye movements relate to the integrity of brainstem structures. Tonic eye deviation indicates integrity of brainstem function. Asymmetric horizontal responses are interpreted as previously described and may give localizing information. Lack of any response may result from lesions of vestibulo-ocular reflex pathways in the medulla or pons, the 8th cranial nerve, labyrinth, or drug intoxications, such as those resulting from vestibular suppressants, barbiturates, phenytoin, tricyclic antidepressants, or major tranquilizers, and neuromuscular blockers. The presence of caloric-induced nystagmus in an acutely unresponsive patient suggests a psychogenic cause of unresponsiveness. And that is calorics. Have a great day.